The Somerville Foundation Annual Conference 2014. Arrhythmias, Diagnosis and Management by Dr. H. English, Consultant Cardiologist, Leeds General Infirmary. About the speaker, Dr. H. English. Dr. English is a Consultant Cardiologist at the LGI. She specialises in adult congenital heart disease, with special interests in transition, pregnancy and diagnostic cardiac catheterisation.
Thank you. I don't understand Twitter at all. So, arrhythmias, diagnosis and management. So I'll try and, it's quite difficult for medics to alter their language into language that
we can
who
understand.
aren't medical can understand. So if I've written things that don't make sense, just stop me. Basically, arrhythmias are abnormalities of heart rhythm, and the heart can beat too fast or too slow. And they're really common in the ACHD population. And I'm afraid to say that they increase in frequency as you get older. Certain conditions are much more prone to arrhythmia than others, and arrhythmia is the most common cause of acute hospital admission. And the symptom of arrhythmia, so palpitations, are an extremely common symptom, but it's definitely the most common thing that will land you in your local A&E department. As some of you in the audience already know. I was thinking I don't do quite a lot of DIY. My husband does quite a lot of DIY, and my patients will know that I talk quite a lot about wiring and plumbing. So the heart rhythm is controlled by a wiring system within the heart. In the same way as you have a wiring system within your house, you have a wiring system within your heart. So they're not real wires, they're fibres which carry electricity, and they carry and control the electrical impulses which are what control your heart rhythm. So the heartbeat starts off up here in what's called the sinus node or the SA node. And this is a special patch of cells within the heart which sends a trigger of electricity out to the rest of the tissues within the heart. So the heartbeat starts here, and it sends a trigger across the two collecting chambers of the heart. And then that electrical impulse hits this other patch of cells here, which is the AV node, which then sends the electrical signal to the two pumping chambers of the heart down this pathway, and then which then splits into two. So this is the wiring system. And arrhythmias occur when something goes wrong with your wiring system. So just in the same way as you occasionally need an electrician to sort out the wiring in your house, you will occasionally need a cardiological electrician to sort out the wiring in your heart. Why does it go wrong? Sometimes wiring just degenerates due to age. So you've been in those houses that have those round light switches and very old wiring which degenerates. I'm afraid to say that that's the same for all of us. So pacemakers and things are very, very common in the general population as people get older. If you stretch your wires, and that's usually due to enlargement of the heart chambers, then they can have problems with the way they work. If you get scar tissue which forms in your heart, forms either around or through the wires at the site of old surgical cuts or patches, you can also get immediate damage to the wiring system at the time of surgery, and some of you will have pacemakers that were put in the first few days or a couple of weeks after your operations were done, because the surgeons were operating in an area which involved the wiring system of the heart, and the wiring system was damaged at that time. So the wiring can be completely cut. It is possible to bruise the wiring system at the time of surgery. So some people will come out of surgery requiring a temporary pacemaker, but over the course of the next few days and weeks that wiring will recover and will start to work normally again, and will mean that you won't need to have a permanent pacemaker system put in. Some people also get short circuits in the wiring system, and we'll talk a little bit more about those. So how do we examine the heart rhythm? Everybody in the room will have had an ECG. This is what an ECG looks like, and this is how we look at heart rhythm. Now, ACHD cardiologists are a bit geeky, and we kind of see an ECG as a bit of a window into looking at your heart. So it tells us loads about your heart. It's something that's done at the beginning of every clinic. It's dead quick, but we look at them and think, oh, there you go. So we look at rhythm, and this is what the ECG shows us. So this image here is one of these complexes. The P wave is the first bit of electrical activation of the heart. So that's the two collecting chambers which pump. This is the electricity passing through to that next special patch of cells, the AV node, and this big spike is the electrical activation of the two pumping chambers of the heart, if you're lucky enough to have two pumping chambers, that is. So this big spike is from the pumping chambers, and this is the heart, essentially the electricity of the heart sorting itself out. So it's called repolarization. So this is easy. Too fast or too slow? Too slow. The longest, so this is a 24-hour tape, and this is a pause in the heartbeat. The longest pause I've ever seen on a 24-hour tape is 26 seconds. And that was in a man who, this is a few years ago, was in a man who had been admitted to be to a neurology ward to be investigated for fits. And he had a fit on the ward, and he had his 24-hour tape on at the time he had his fit. And this is in the days when people didn't analyse things very quickly. So his tape was taken off, put in the pile to be analysed, he was sent home, and then it was analysed, and he had a 26-second pause on it at the time he had his fit, which was the cause of his fit, obviously. So I rang him at home, and I said, oh, I think you need to come back into hospital. And he said, oh, jolly good, I'll just go get in my car. I said, no, don't drive, please don't drive. He had a pacemaker put in, he was fine. So, slow heart rhythms first. These are called bradycardia. So if you see in your clinic letters bradycardia, that's a slow heart rhythm. And these usually present with either dizzy spells or collapses. They're more common in certain conditions. So anybody in the room with a mustard or a Senning operation for transposition of the great arteries, anybody with congenitally corrected transposition or Fontan operations, bradycardias are quite common. We treat bradycardia, so slow heart rhythms, we treat with a pacemaker. So it only treats slow rhythms, it does not treat fast ones, a basic pacemaker. There are usually two leads, so this is the pacemaker box which sits under the skin. There are two leads which go into the vein, one sits in the atrium, one sits in the ventricle. And this is about the size of a pacemaker nowadays. So it sits in the palm of the... They're quite small, they're getting smaller all the time. And they sit underneath the skin, so we make a pocket underneath the skin to put the pacemaker battery in. I've once seen somebody whose pacemaker eroded, and he attended A&E with it hanging out, and he had it in the pocket of his pyjamas. So what the pacemaker does is it sits within the heart, it watches for the electricity which drives the heart to beat. So if either of the leads don't see an electrical impulse at the time that they know they should see one, it will then give the heart an electrical impulse and cause it to beat. So they're quite straightforward, really. Practicalities of the pacemaker is usually performed under local anaesthetic. It takes about 90 minutes and it usually needs one overnight stay in hospital. Quite often nowadays people are allowed to go home. They need regular checks, battery change every 5 to 10 years depending on how much you use your pacemaker. We tend to recommend to people that they use their mobile phone on the opposite side and let the medical staff know if you're having any operations, because it can be affected by the diathermy that we use to cauterise vessels. You have to be a bit careful at airports going through the security channel. Certain conditions present quite significant, very significant technical challenges if a pacemaker is required. In particular, Fontan patients and patients with single ventricle, it can be technically very challenging to actually get a pacemaker into the right place, and sometimes they need to be done on the outside of the heart via an operation and various other bits and pieces. So, any questions about slow heart rhythms before we move on? Yes?
Would you change it if you get Tachycardia?
It depends on whether there is a vein connecting on this side. So sometimes we will end up putting the pacemaker battery on this side rather than on this side. We will usually, in patients with congenital heart disease, do what's called a venogram first of all, so do an injection of dye into the veins in the arm so that we can see what the anatomy is of the veins. So usually they're put in on on this side of the patient, that's actually because doctors are creatures of habit, and we kind of learn to do things from a particular side of the patient. We're not very good at doing that. But if we need to, we can put them on the other side. But they still, the anatomy is such that the leads will still go into the right atrium. What's morphologically the right atrium and the right ventricle, unless you have a heart which is more complicated.
In terms of on the slow tachycardia, and if you've got a slow heart rate and possibly heart blocking that,
yeah.
if you're not actually showing signs and you're actually coping that all right, can you stay away from pacemaker?
It depends. So we know which conditions are particularly prone to bradycardia. So in those patients, we will usually do 24-hour tapes as a matter of routine every year or 2 years. There are some things that we see on 24-hour tapes and on resting ECGs which give us an indication that somebody is likely to start running into trouble. And even if they are asymptomatic, we would recommend that they would have a pacemaker put in so that we avoid that first episode of collapse. If you have an episode of collapse, it can have implications for work and driving and things like that. So if we see disease which we know is progressive, so problems with wiring system that appears to be progressive, we will sometimes step in and do a pacemaker first. Okay. So fast heart rhythms, tachycardias. You'll see on your clinic letters tachycardia of various descriptions. So this again is a normal ECG. This is quite fast. Kind of hard push to think that was normal. Although I know a few medical students who wouldn't spot that was abnormal. So this is fast and it's a bit irregular. And then this one is really fast and a bit more regular and looks very, very different to this. You see, this is where we start to come on to the ECG being a window into what's going on with your heart. We can tell from that it's fast, but we can also tell whereabouts in the heart that rhythm is coming from. So this very wide complex means that it's coming from the pumping chambers of the heart. So this is ventricular tachycardia. This is coming from the collecting chambers of the heart, the atria. So this is supraventricular tachycardia. So the ECG tells us not only how fast it is, but also gives us quite a lot more information about it. So fast heart rhythms usually present as palpitations. They're often sudden in onset, and you will feel your heart beating very fast. It's a bit like if you go for a run, and that feeling that you get when you do exercise and the heart beats fast, but it's that happening when you're not doing anything, and it feels really weird. They can be regular or irregular. Anything important will last for longer than a few seconds. They often stop suddenly as well as start suddenly, and you can feel quite horrible with these. So people often feel sick, quite faint and quite dizzy with fast heart rhythms. So again, this is a picture of the heart, and these are the two collecting chambers, right atrium, left atrium, right ventricle, left ventricle. My patients in the audience, can you see I have not drawn a square heart? Your heart-shaped heart. Very good. So this is the sinus node, this is the where the electrical activity starts, and it spreads across the two collecting chambers. Any arrhythmia which arises from here is called a supraventricular arrhythmia. Anything which arises from the two pumping chambers is called a ventricular arrhythmia. So supraventricular arrhythmia, supraventricular tachycardia arises from the atria. There are various different ones. Atrial fibrillation, there'll be a few of you in the audience. Atrial flutter, that's very common. Something called re-entrant atrial tachycardia, which needs an accessory pathway. So, for example, people with Epstein's anomaly get lots of re-entrant atrial tachycardia. And also ectopic atrial tachycardia, which is when you have the sinus node, but you have another little magic sinus node which takes over, and it beats a bit faster than your sinus node, so it's called ectopic because it's not where it should be, and it drives the tachycardia. They're often related to surgical scar. So people with repaired ASDs, for example, there'll be surgical scar that can drive atrial tachycardias. Anybody with chamber stretch, so unrepaired atrial septal defects, big atria, that can drive atrial tachycardia, or electrical short circuit. They are often recurrent, so anybody who's had one episode of atrial tachycardia, the chances are at some point in the future you will get it again. some of them will go away on their own, so last for a minute or two and then it will stop. Some will be terminated by things that you can do yourself, which we'll talk about a little bit more, but basically a Valsalva manoeuvre, what we call a Valsalva manoeuvre, which we describe to people as imagine that you're doing the biggest poo you've ever done in your life. So deep breath in, push out as if you're straining really, really hard, and that will sometimes get rid of these arrhythmias. We have one patient who does handstands to get rid of them. And it worked, it was great when she was a kid and she could do handstands. Everybody thought she was just doing handstands. I think she's a law student or something like that, and now she's a professional woman and she does handstands and has to show her knickers. Anyway, people find ways to sort these things out. And then some of them you can't terminate yourself and you will need to come into hospital for us to sort them out. Supraventricular tachycardia is usually not too dangerous, and we'll talk about why. If it goes away on its own after 10 to 15 minutes, fine, all well and good. If we treat them relatively quickly, so they're usually not too dangerous, but they can be frequent, so they can come very often. You get repeated episodes and they can be a right pain in the neck because you'll end up having to go into hospital to have them sorted out on a repeated basis. So they can be very, very debilitating and annoying. The reason that supraventricular tachycardia is not particularly dangerous is because your heart has its own protective mechanism, which is the AV node. So you have to think of it like the fuse box in the heart. So you've got tachycardia, which is arising up here. To get through to the main pumping chamber, it's got to get through the AV node, and that's essentially your fuse box. So this won't let very, very, very fast heartbeats get through into the pumping chambers. So these can be going at 300 beats per minute, but that bit, your fuse box, won't let the pumping chambers pump that fast. They'll limit it to probably around about 150, 160 beats per minute. So you'll feel horrid, but you won't be keying over. That's good. Okay. So how do we treat supraventricular tachycardia? So acutely, so if you get palpitations, if the heart's beating really, really fast, these are the things we do. So Valsalva manoeuvre we just talked about. Drugs, we use intravenous adenosine. Don't know if any of you have had adenosine. Some of you will have done. It's got what we call a very short half-life. So when you inject it, it works really quickly and then it goes out of the system. But basically what it does is it stops the heart for a very short period of time to allow the proper heartbeat to kick back in. It feels horrible for patients. So when you inject it, it feels like everything's stopping. And I have had people say to me, if you give me any more of that stuff, I'm going to thump you. So we use adenosine, amiodarone, some of you will have had, flecainide, beta blockers. Lots of you will take beta blockers orally, but we can use it acutely, intravenously, and verapamil. Cardioversion, loads of you will have had cardioversions, quick general anaesthetic, quick shot to the heart to get it back into a normal rhythm. Sometimes we use overdrive pacing, so pacemaker, we can pace your heart faster than the abnormal rhythm to try and capture the heart and bring it back down to normal. So chronic treatment of supraventricular tachycardia, I take quite a pragmatic approach. If you've had one episode, I usually don't do anything because you might not have another one for 2 years and you get away with 2 more years without taking anything. If you start to get repeated episodes and they're causing problems, we would address any underlying structural problems that you have with your heart. So if you've clearly got a leaky valve, you've got chamber stretch, and we think that we can address that either with surgery or intervention, then we would do so. You can take daily drugs, and there's loads of different things that we use. Basically, they're all okay, none of them are brilliant, none of them work 100%, you'll still get episodes of breakthrough SVT. Nothing you can do about that. We try and avoid horrible things like amiodarone for supraventricular tachycardia, because it's relatively a benign thing. Amiodarone is not a benign drug, so we try and use things in proportion to the abnormality that they've got. Electrophysiological study and ablation, we'll talk a little bit more about that. And we sometimes use anti-atrial tachycardia pacemakers, particularly if you've got a need for a pacemaker anyway. So for quite a lot of people, we have 2 problems coexisting. We have slow heart rhythms and fast heart rhythms. If you've got a need for a pacemaker for slow heart rhythms and you're troubled by fast heart rhythms, we might put in an anti-atrial tachycardia pacemaker, which has a function which will overdrive pace if it sees a fast rhythm. This is an EP study. This is the inside of the heart. This patient is in the cath lab, and basically we put catheters, tubes into the heart from the vein in the leg, and we put these electrodes within the heart. We try to trigger the abnormal rhythm. If you can trigger the abnormal rhythm, you can map it. So you can essentially make an electrical map of the inside of the heart, and then you can zap the bit that's causing the problem. Some people have had loads of these done. They take hours. It takes a really special type of cardiologist to do electrophysiology. It's really boring. So they're in the cath lab for hours and hours and hours, mapping. So they're normally done in the cath lab. Dr. Ernst at Brompton is now doing these MRI guided, and the technique is absolutely fantastic. It's really, really amazing stuff. So those people who've had sort of failed EP studies and ablations in the past, there is a bit more now in our armamentarium to try and do it again with MRI. We're guided with MRI. This is what Tony Blair had done to his arrhythmia. Didn't have to do heart disease, but he had an EP ablation. So, ventricular tachycardia, these are the ones that come from down here, arise in the ventricles. Because it bypasses the fuse box, the heart can go extremely fast, and that leads quickly to very low blood pressure and can make you collapse. Those very fast heart rates, so ventricular tachycardia is the dangerous one, that can be dangerous. It's often related to poor function of the pumping chambers, scars on the heart from previous surgery, or chamber stretch, or all three. And it usually presents as sudden onset, very fast palpitations associated with somebody feeling really pretty unwell. And that's what it can look like. So it says 262 beats per minute. You'd be feeling pretty unwell if your heart's doing that. So, treatment of ventricular tachycardia acutely, cardioversion, so most people with an ECG that look like that would get cardioverted in A&E. And we may not even wait for an anaesthetist. We might give you a slug of a drug that will make you flattened, just shock you and get you out of it. We use intravenous drugs sometimes if it's a bit slower than that and you appear to be stable and coping. We would use amiodarone or beta blockers intravenously. The treatment of sort of chronic treatment of VT, once you've got sorted out an acute episode, is treat the underlying structural problems within the heart, daily medication, implantable defibrillator. This is a defibrillator. What's gone wrong with that picture? It's a bit strange. Anyway, if you put the three bits back together, it looks like a pacemaker, but it's bigger. So this is a pacemaker, this is an ICD box. And basically it has an extra lead within the heart. It senses what's going on with the heart rhythm, and if it sees fast heart rhythms that it thinks are dangerous, it will give your heart a shock. Now, you would hope that by the time it gives your heart the shock, because it sees it, it checks it, it charges, it gives you kind of 10-20 seconds, by the time it gives you the shock, that you will be feeling fairly faint, should I say, or unconscious by the time it gives you the shock. They can sometimes give you a bit of a bump if you're still conscious when it gives you the shock, but if it needs to do it, it will do it. A word about ectopic beats. These are really, really common. They're completely benign. They occur in everybody, and they often come in clusters for a few weeks and then ease off. And they feel like a jump or a bump or a lurch in the heartbeat. They often cause you to catch your breath. They make you feel, oh, what was that? And they're usually worse in the evening when you're sitting quietly or when you're in bed, and they usually don't feel them very much when you're active or doing stuff. They're worse with stress, they're worse after alcohol, so normally not when you're on your night out, but the next day, and they're worse with caffeine. This is what ectopic beats look like on an ECG. So basically you've got a normal beat, and then your heart puts in an extra beat. Normal beat, heart puts in an extra beat. So what you feel is flutters, and then generally a flutter, and then a bump, and they're ectopics, and they're normal. But lots and lots of people feel them and get quite worried about them. So, I have a thing about palpitations. I see loads and loads of people with palpitations. Basically, in my mind, I have to work out whether they worry me or whether they don't worry me. So, worrying ones, sudden onset and offset. So, sudden, they come on like that, they just start, and they stop in the same way. Very fast, associated with dizziness or collapse, make you feel rotten, sickness, vomiting or diarrhoea. Those are signs of low blood pressure. So, if you've got fast palpitations and you feel like you need to go to the loo, or you're sick, then it's because your blood pressure is really low. And these ones last longer than a few seconds. Ones that don't worry me, gradual onset or kind of, they start slowly and I didn't really notice how they went away, but they eased off. They only last a moment or a few seconds. You don't feel ill with them, and they're flutters, bumps or lurches. Those are generally benign and not causing any trouble. So, if you get palpitations, if they start suddenly, they're fast, they make you feel poorly and then carry on, you should dial 999 and come to hospital. If they come and go, if they feel like bumps and lurches and they're momentary, you should probably just mention it at your next cardiology appointment. You probably don't need to do anything else. You could bring specialist nurses if you're worried. If you've got them that start suddenly, stop on their own after a few minutes, they feel fast, but you don't feel unwell, then I would suggest that you contact your cardiology team for an early review. What we would usually do is arrange, first of all, for you to have a 24-hour tape done fairly quickly. So how do we investigate? We can only make a formal diagnosis, so we can only be absolutely sure about what's going on if we can get an ECG during an episode of palpitations. So an ECG when you've not got palpitations it doesn't help us. So we use various different ways to try to get an ECG during an episode. So standard 12 lead, so if you feel the palpitations, if you can find the nearest place to get an ECG done before they stop, then that's really helpful. Local A&E, GP surgery, ambulance, they will only be able to take a 12 lead ECG. 24-hour tapes, best way in the world to cure palpitations is to put 24-hour tape on. Anybody ever had palpitations with a 24-hour tape? Likewise, a 7-day tape is just a way to spend even more NHS money and not to get because we never get anything. Cardio memo saying, and then we use reveals. Quite a few of you will have reveals in. This is the old reveal, and this is the new one. Reveal link is this big, and we can put it in with an injector. So we put a little bit of local anaesthetic in, put the injector in, and stick it in under the skin. Lovely.
It's wireless, is it? Wireless.
Yeah, so it's a loop recorder, so it records the heart rhythm on a loop, and it has an automatic detection thing. So if it detects an abnormality, it stores a segment in its memory bank, and then it starts recording on a loop again. And it records, I think, up to 6 automatic things, and then you have a little device which, if you feel a palpitation, you can tell the device to store that segment. So you just stick a thing over the skin and click it, and it stores that segment, so it stores the rhythm, and then you can download it wirelessly down the phone to us so we can have a look at it. Reveals cost about, George, do you know?
They're about £1,500.
Yeah, so about 1,500 quid. But they're a brilliant way for us to get a diagnosis. So if by the time we've done 6 24-hour tapes and driven you all potty with stickers on and things, and spent about the same amount of money, we might as well have just stuck a reveal in and we'll have an answer. And they last, the batteries in them last about 2 years, and if you're having arrhythmias but you've not had anything after 2 years, it's probably not something that's desperately important anyway. So they're probably going to become more and more used. We use them a lot, but they're probably, because it's now smaller, it will probably get used more. We just stick them in the skin. In ladies, we usually put them under where bra straps go so that you can't see them and they leave a little scar. And then electrophysiological studies we do use sometimes in people who have a very clear story that they're getting important arrhythmia, but we can't demonstrate it through whatever means that we use. We would take them to the lab and have a look. So arrhythmias, important arrhythmias are really common in ACHD patients, and so they do increase as you age, can be a sign of an underlying issue with the structure or the function of the heart. Palpitations can be a sign of important arrhythmia, but they're really, really common, and they're very often nothing to worry about. So people do get worried about them, and rightly so, but often they're not something that's going to cause you any problems. Your palpitations should be assessed by a cardiology team, and we have loads of different ways to treat them. So loads of different drugs, electrophysiology, Sabine's new MRI-guided EP ablation, and other things. Some arrhythmias can be pretty resistant and quite difficult to treat. And that's it. Thank you very much.
The Somerville Foundation, supporting young people and adults born with a heart condition. The Somerville Foundation works with patients born with a heart condition. congenital, providing practical and emotional support and enabling them to take control of their lives and manage their own heart condition. Thanks to advancements in medical treatment, today more and more people born with heart conditions are living full, long and happy lives. To learn more about the work of the Somerville Foundation, visit www.thesf.org.uk.